Good evening to the all. Welcome to our sessions of the series for the YouTube specialized for the FOP and TAS. I am Dr. Sarah, one of the mentors in the StudyMEDIC, today introducing the pediatric life support. Welcome to our lectures and hope we will enjoy the learning together. We will start our learning objective by knowing what the structured approach for the seriously ill child. We will go through cardiopulmonary arrest, anaphylaxis, shocking, and status epilepticus, and our favorite part for the questions and answer. So let's be started. In the critically ill child, the primary assessment is the rapid initial clinical assessment for the seriously ill child or young person and should be conducted with the ABCDE approach. We have a pediatric early warning assessment score, which can be assigned and assessed through the first looking for the child, and even without touching him. If we will saw the appearance of the child, it will reflect it for us the level of the consciousness level and central nervous system. If we noted the breathing through the effort, through the sounds coming from the child, it will be going with the breathing part and respiratory part. What they're reflecting for the circulations and the perfusion, it is the coloring for the child. If the child is pink, if the child is pale, if the child is cyanosed, so our pediatric early warning score will coming from seeing without touching the child and to define is the child is critically or no. So what the causes can lead the child to enter in these critically ill conditions? We will start to know what will affect the respiratory causes, what will affect the airway and the breathing. We have upper airway obstructions like foreign body, anaphylaxis, some infection like screw, tracheitis, epiglottitis, and what will obstruct the lower airway like asthma, even infection like pneumonia, or sometimes it will be not in these two things. It will be from central part, like poisoning, will affecting the central breathing from the brain and reflecting to the respiratory system. In the circulation part, any type of the shock can enter child in the critically ill conditions, hypovolemia, cardiogenic shock, and anaphylactic shock, obstructive shock, and so on. In arrhythmia part, we have all heart conditions and arrhythmia, tachyarrhythmia, or even bradyarrhythmia enter him in critically and need to act according to that. So let's see how we can assess this primary assessment, which is started by the ABCD. In the A, reflected the airway. We will go through the airway and breathing together. We need to look and listen and feel if there is any effort for the breathing. What obstructs the airway? If there is any respiratory distress, if there is any more effort, work with the breathing, intercostal, subcostal, suprasternal recessions. While that all working, what is the respiratory rate? What is the sound coming from the child? Where we will auscultate for him or her. If there is any stridor, any wheeze, if the air enter bilaterally, what the added sound we can listen to him. Bronchi, crepitation, crypts, cyanosis coming from him peripherally or centrally through the lips. All this will be assessing while saturations will give us the severity for that decrease for the respirations and the airway. If they're going to see the airway, how we can correct this? We need to consider to open the airway through the jaw and neck repositions. Give him supplement oxygen, do suctions as needed. If we can remove any foreign body, we will go through that. We will support that breathing before we will go to the circulations. While that, we will feel and assess if the heart rate is present and where we can assess this area. If it is less than 1 year, infant will be in the brachial area or in the carotid for the older. The heart rate, the rhythm, according to that, the pulse volume, assess the capillary refilling, and monitor and measure the blood pressure to complete the whole area for assessing for the circulations. Whenever if they're absent for the heart rate, or even the heart rate less than 60, we need to go to the chest compression until we restore the circulations. But if it is everything is within little normal range and not critical, we will go to disability to observe and note it, the level of the consciousness. We have quick, rapid review for the level of the consciousness, which we called AVBU. The A reflected the alert, conscious, the V responding to the voice, and the V responding to the voice, the B responding to the pain, and the U is unresponsive child. Each of these will equalize something in long Glasgow scale for the pediatric age group. So whatever the child alert and conscious, that means 15/15 from the Glasgow scale. Whatever he is responding to the pain, that may be he will be equal or less than 8/15, and he high risk for airway and better to prepare the child for intubations and measure according to that. What is the pupil reactions and pupil size and reactivity bilaterally or no? If we will go to the exposure, we will observe for the whole extremities and expose that one. We will search for the rashes, bruises, sign of the trauma, ABCDE, and we need to measure the temperature and check for the fever if it is there. Let's see, our primary assessment was little reassuring. So we will go here to the secondary assessment through full history, and it will be a focus one, and finishing by head-to-toe examination, searching for any extra sign and symptoms on the child body. We will not forget to do the blood glucose and do needed after that for the emergency treatment. Our vital sign here, we will find whatever the child is small, it will be in the higher side. Middle age will be little middle vital sign, and near adolescent will be near adult vital sign range. As we mentioned, our respiratory rate, our saturations, going to the find if there is pulse present, and that pulse, what is that? What is the rhythm? Following by monitoring the blood pressure and see if the capillary refilling is prolonged. We have here two places to detect the capillary refilling. Either it is in the peripheral part, or sometimes we can do above the sternum on the trunk of the child. And in the exposure area, we will not forget the temperature. How we will do that intervention for our critically ill child? We will complete our assessment, which we mentioned before, within less 1 minute. We'll find the problem. That means we identify what is the issue in the all three primary assessment, the main things, the airway, the breathing, and circulation. Will recognize what these abnormality. We will interfere as needed and give the proper management through stabilizations and to prevent deteriorations. And in the meantime, we will not forget to measure the blood glucose and to administer, if there is a hypoglycemia, 10% 3 ml of kilogram following by the IV glucose infusion. So let's go to our first topic here to complete the first assessment, which is the algorithm of the cardiopulmonary arrest. Usually, when we find child collapsing in front of us, we will need to check the environment in the first part, calling for the help if there is more than one rescue, and to prepare defibrillator if needed later. So here, we take the child from the danger, we stimulate him to ask, "Are you okay?" And we will shout for help. We will open the airway maneuver to check and listen, feel, and look. Through what maneuver? We have here our two maneuver, either to open through head tilt chin left or jaw thrust. In both of them, we will mean opening and maintain this airway to give what? To give 5 rescue breathing through ambo bag or bag and mask ventilations. But if we don't have it, shall we cannot do this? The answer will be exactly no. We will do for the infant good tight seal covering the mouth and infant and give him and blow over 1 second. If it is older child, we will just pinch the nose and do mouth-to-mouth breathing till the equipment suitable one will be available and give that rescue breathing. We will recheck for the pulse less than 10 seconds and to know if it is there or no. We mention if there is no pulse, absent breathing, or the pulsations less than 60 per minute, we need to initiate chest compression every 15 to 2 ventilation in the 2 rescue, helping the child. How we can do that chest compression? Here we are demonstrate if the older child, we will do through both hands. For infant, we have 2 things, either through circulating or 1 hand, and thumb two finger technique is no longer, I think, used, except in the neonatal age group. While we are checking for the no pulsations and connecting to the monitor, the rhythm will be analyzed and give us 2 types of the rhythm. Either the rhythm need to be give the shock for the child, or that rhythm it not needed to be shocked, which we called non-shockable rhythm. In non-shockable rhythm, we have 2 things. We have asystole, that means 1 line showing in the rhythm, or pulseless electrical activity. What that mean? That means there is a good pulsation. In the monitor, we can see the sinus rhythm. But actually, when you put your finger to check the pulse on the child, there is no pulsations. That means the heart is not pumping. Only it is fake rhythm on the monitor and no rhythm on the child. So these 2 kind of the rhythm, either asystole or pulseless electrical activity, need to give him continuous CPR with medication for adrenaline every 4 minutes, and we will not forget the reversible cause till we restore the circulations. So what is the difference between here and shockable rhythm? Shockable rhythm that we mean we need to shock the heart and let him to switch off and restart again, because this medication or that part of the working for non-shockable rhythm, it will not work on it. So here we have starting by 4 joule per kilogram, and we will give first shock, second shock, while adrenaline giving in between, and we will consider to give aminoturone after 3rd and 5 shock only, till our heart will be restored and sinus rhythm to be returned. Again here, our consider causes, reversible causes in our 4 H's, 4 T's to be putting in our mind. blood can be extracted and sent, and whatever needed to be done. So let's see what these 4H's and T's and what the specified management needed for that. We can find first one in the 4H's is the hypoxia. We need to give him oxygen through the ventilations, simple by bag mask or advanced airway through intubations if needed. Hypovolemia through intravenous fluid or even blood, depend what the type of the loss is. Hypothermia, warming by the blanket and give him warm intravenous fluid. In the hypokalemia, we will give intravenous potassium, but in the hyperkalemia, we will give nebulized salbutamol plus insulin and dextrose. Let the extra potassium to be enter to the cell. For the tension pneumothorax, which started in the 40s, we need to do quick intervention in the form of the needle thoracocentesis or needle decompression. Same things will be for the heart, for the cardiac tamponade. We need to do pericardio decentesis. In the toxin, if we know it, we will give antidote like naloxone for opiate, and we need to contact the toxology center. For the thrombosis, we need to give thrombolysis and anticoagulations. Is our resuscitation for the child have any limitation or any time to be stopped? Let's see what mentioned at the guidelines. There is no limit time to give durations for the CPR. The cases should be managed in individual basis. But if we do a prolonged resuscitation, we consider it is successful in these conditions. In the hypothermia, less than 32 degrees, if it is happen, overdoses, and to depressive for the cerebral, in the main condition for the intact neurological condition after 24 hours. That means the outcome will be better and the CPR will be success. And the last things here, discuss the difficult cases with the consultant before abandoning resuscitations, because each cases, it should be managed individually. So let's go to anaphylaxis, which is happening more frequent than 3 years of the age and even for the older, for the children. Usually, we will start by assess how the child become after he shock or he is getting anaphylaxis. We have one major things. Usually the skin changes will be usually there in the form of urticaria. Plus, for anaphylaxis, there is 2 or 3 systems to be involved. We will start by the respiratory. So we can find the airway become narrowing, swallowing, and there is some extra sound to be heard, either hoarse of the voice or stridor. The breathing will be increased, tachypnea. The sound will be heard, maybe in the form of the wheeze, and the saturation will be dropping less than 92%. While that, this affecting on the circulation, and the child will be looking pale, cold extremities. We have weak pulses, and if we measure the blood pressure, we can find him low. What will happen for his awareness, his level of the consciousness? It can be altered, it can be fainting, it can be lethargic, it can be drowsy, and in the severe things, it may enter in the coma. So our assessment will be in the form for skin changes plus 2 major systems to be affecting. So what the immediate action I need to do? It will be, after calling the help, to administer the IM adrenaline. Give after that the oxygen supplementation. Assess whatever the sound you are hearing. If there is any stridor, to give him nebulized adrenaline, or wheezing, to give him nebulized salbutamol. While assessing and taking vital sign, connect to monitoring. helping is coming. What is the blood pressure? What is the capillary filling? It is prolonged. It is reflecting that he is not compensating with everything is happening for the child. So in this part area, 2 IV line access to be there and fluid 10 ml of the bolus from sodium chloride 0.9% to be administered. All this measurement you are doing, if this measurement end with stabilize the child, or you are thinking to repeat the adrenaline through the IM again, while that you are waiting for the reassessment and to see if these all things end with the improvement, or you are going with the refractory anaphylaxis, which mean here you need to react differently in little part. So what is these different part you need to do? We mentioned that blood pressure is already affecting. You started already by 10 ml per kilogram, and you are following your local protocol. Adrenaline, you can even again repeat it and giving infusion instead of the IM, because already 2 doses previously given. While doing that, you can repeat it to be given every 5 minutes and consider to give second vasopressor like noradrenaline and ask your pediatric intensive care unit specialized to be prepared and administer corticosteroid. Even with that, it can give less effective because usually it will not work before first 1 or 2 hours later. But this measurement, it will help to minimize the time for responses for the child and get him out from recent anaphylaxis shock enter for him. Hope what we giving in the previously was clear, and let's see what will happen if the child is shocking. When we suspected the foreign body in the airway for the child, after asking for the help, we need to see is this cough is effective, and in that part, we will just need to encourage the cough, let the object who obstruct the airway to be out. But we have 2 things. That means the cough, if it is ineffective, but the child is conscious. Here, it will be our intervention according to the age. For infant, we will give 5 back blow and 5 chest thrust. But for the child, we will give 5 back blow and abdominal thrust till the object will be okay and further care will be follow up. But if the cough is ineffective, child unconscious, that means he is entered from the partial obstruction to complete obstruction. And while that, maybe he's not breathing, maybe his heart not beating. What we need to do? Here we need to initiate the basic life support in the form of the chest compression with rescue breathing. We can try the rescue breathing before going to the chest compression directly, but you will note it after this rescue breathing, if there is any response or no. We summarize this here in another algorithm here. So, according to the severity of the shocking, with the partial obstruction, effective cough encourage him till the object will be out. And severely obstruction, incomplete, whatever is conscious, we will go the maneuver. But if it is unconscious, we will start our CBR. Our picture here to demonstrate helmic maneuver, abdominal thrust with the back slap for the 5 back slap, or chest with the back slap for the infant. We are going now to a review for status epilepticus, mainly the approach for the management. Usually, when receiving a seizing child in the emergency department, or even in the outside hospital setting, what the things you need to do? After taking him to the safety place, assess his ABCs, the airway, breathing. If you can obtain the IV line, you can do. If you can extract some blood tests, including the blood glucose, and to do these medications. What medication we want to do? If we don't have access, we need to give through in the mouth area the buccal midazolam. Okay, so if we do have access, it is preferred to be give lorazepam. Okay, if the access is still difficult, but we are in the hospital, we will need to give the diazepam. So here, from the group of the drugs, benzodiazepine, we need to give only 2 doses from all these 3 medications, either buccal midazolam or IV lorazepam or berrectam for diazepam. We can have a chance to repeat these medications again. So while obtaining the IV access, we will give the lorazepam again. We hope the seizure will be stopped. Otherwise, we are going to prepare levetiracetam infusion over 5 minutes. The second option after this will be phenytoin to be giving loading dose 20 milligram through the 20 minutes. Usually here, when we reach this step, our 10 minutes will be passed. So what we prepared, the encephalopathy will be entered for the child. The glaucoma will be dropping less than 8. So here it will be critical time to prepare the child for the intubations and call the anesthesia and intensivist and follow our regional protocol and send him to the BICU. But we need to note, if the child is non-epilepsy or non-seizure disorder, we need to give him drug not previously noted to let that drug to be effective and used. And this is essentially for each child non-epileptic disorder. Otherwise, in the healthy child, we can start, as we mentioned, by levetiracetam and phenytoin, preparing for intubation, call the anesthesia and intensivist, and transfers him for the BICU and regional transport surface. Let's start our peripheral part for the questioning and answering. We are making him the headline for each questions, but for the initial, we will just read the scenario and going through the options. So our first questions, you are performing a primary assessment on the 3-year-old child who looks unwell. Which of the following is the most reliable early indicator for the compensating shock in the child? Concentrate here. He asked most reliable indicator for the compensating shock. That means the blood pressure is not dropping. He is in the compensating part. His measuring for the circulation is still in the stabilized area or time. We didn't enter in the critical part for non-compensating or shock. So what the options? It is hypotension, it is bradycardia, it is tachycardia, or reduced level of the consciousness, or even sunken eyes. Let's see what we can eliminate it from here. Usually the hypotension is the red sign. Even we can consider the bradycardia with this. Sunken eye, it's a part of the shock or it is a sign of the dehydrations. So either we will choose tachycardia or reduced level of the consciousness. So let's see the answer. Our answer here is tachycardia. Why? He mentioned in the early compensating shock, blood pressure is maintained through the compensatory mechanism. Tachycardia is an earliest and most sensitive indicator for the shock. Then hypotension, which is the late pre-terminal sign, signifying that compensatory response are failing. Our second scenario, a 4-year-old girl with a severe asthma is assessed in the emergency department. She responds only to the painful stimuli. What does this score on the AVBU scale signifying regarding her airway? Is this her airway is patent and safe, or alert and need no intervention. She responds to the voice, she need only for oxygen, or her airway at risk and need maintenance and interventions, or she is unresponsive and need immediate CPR. If it is responding to the stimuli, that means she's not in the last options. Responding to the voice, that means his glaucoma scale more than 13 above. Alert, that means there is no need intervention, so it's not here. So we are to know either she's airway is patent or safe, or her airway at risk and need immediate intervention. And most probably the answer will be the last option, which is the D. Her airway at the risk and need maintenance. Why? He tell you a score of the B respond to the pain on the AVBU scale or a glaucoma scale score. It will be equal less than 8. Indicate that the child's airway at risk and will need to be maintained by the maneuver or adjust. So what maneuver? After opening airway, to keep it maintainable through simple device or pharyngeal or nasopharyngeal airway or advanced airway in the form of the intubations. Our third questions. You are in the restaurant and see a 18-month-old child suddenly started coughing and then become unable to breathe or speak. The child is conscious but has an ineffective cough. What is the first line interventions? So we noted here, he is conscious plus ineffective cough. So here we will go not in the algorithm, in the ineffective conscious child. So what we need to choose, perform a blind finger sweep, give 5 back blows followed by 5 abdominal thrust, give 5 back blows followed by 5 chest thrust, encourage the child to cough, or start CPR. According to the age, this is 18 months. Are you considering him as infant or are you considering him as a child? Let's see. We need to give him 5 back blow followed by 5 abdominal thrust. That means for a conscious child over 1 year of the age with a severe airway obstruction, ineffective cough, the management sequence is 5 back blow followed by 5 abdominal thrust. Chest thrust are used instead of the abdominal thrust for infant under 1 year of the age to avoid injury to the abdominal organ. The fourth questions. A 10-year-old boy present with a sudden onset of the wheeze, stridor, generalized itchy rash after eating a peanut butter cookie. He is pale and has a heart rate of 140 beats per minute. What is the immediate priority treatment? So here, let's see what is the anaphylaxis going with this symptoms with the child. He mentioned he had sudden onset of wheeze and stridor. This is evidence of the obstruction of the airway. After eating peanut, heart rate is already affecting, and there is generalized rash. So there is evidence of the urticaria, usually, with 2 system involvement in the respiratory part and in the heart and in circulations. In the circulation, you can find he has become pale and the heart rate. He just missed here to tell you if the child is conscious or lethargy or drowsy. So even with the CNS or central nervous system affection, there is evidence it can be expected to be involved. So there is anaphylaxis happen. So what the immediate priority here? Shall we can give him oral cetirizine or IV hydrocortisone, nebulized salbutamol because there is evidence of the wheeze, or IM adrenaline, or IV bolus of the normal saline. We mentioned there after our assessment for the severity for these symptoms, first option will be IM adrenaline, which is the immediate treatment for anaphylaxis administered in the mid-outer thigh. For the child age 6 to 12 years of the age, the dose is 300 microgram, 0.3 ml in 1,000. Other treatment like fluid steroid and antihistamine are secondary to adrenaline. So the priority here to give him the first dose of the IM adrenaline, following his response, repeated if needed, plus these medication to be administered as indicated. Our 5 questions. During a resuscitation attempt on the 12-year-old child, the monitor showed ventricular fibrillation. Ventricular fibrillation and pulseless ventricular tachycardia, it is going with the shockable rhythm. So here he tell you a DC shock of the 4 joule per kilogram has just been delivered. What is the next immediate action? After we give this bolus immediately, what we need to do? Shall we check the rhythm on the monitor or palpate for the carotid pulse or resume chest compression for the 2 minutes or administer 1 milligram of the adrenaline IV or maybe give IV amiodarone? Let us to remember when we can give this, we mentioned we can give after 3rd shock and 5th shock, the 3rd and the 5th one. So adrenaline, it be administered every 4 minutes and will be continued. So what immediately after this shock given? It will be resuming for the chest compression for next 2 minutes. In the advanced pediatric life support shockable rhythm algorithm, the rescue must immediately resume the CPR for 2 minutes after delivering a DC shock without stopping to check the rhythm or pulse. Adrenaline and amiodarone are only administered after the 3rd shock. Our 6 questions about a 2-month-old infant is brought to the hospital with the poor feeding and tachycardia. The ECG revealed a regular neurocomplex tachycardia with a heart rate of 280 beats per minute. The infant appears stable and is not in shock. What is the first-line treatment? From the definitions and descriptions for the ECG here, regular neurocomplex tachycardia and the heart rate for these infants more than 220, this is consist with the supraventricular tachycardia. The specific things in the ECG, there will be narrowing for the QRS and absent B wave. So he give you very good informations. This baby is stable. That means his blood pressure is maintainable with the normal limit. So what we need to give? We need to give synchronized D-shock of the 1 joule per kilogram or IV adenosine bolus, immersion of the face of the ice water, or vagal maneuver like Valsalva, or IV amiodarone infusion. In the stable SVT, usually we will start by vagal maneuver. Then we will go to the medication. Then we will go to the shock. So initial, first, stable SVT, we'll go with immersion of the face for the ice water. For a stable infant with the SVT, the first line is the vagal maneuver. In infant with the diving reflexing, using the ice bag or face immersion in the ice water. This is the recommended technique. If these failed, the medication will be in the second part. The IV adenosine is the drug of the choice. But DC shock is reserved for unstable patient with a sign of the shock. And here we have small noted. The shock for SVT should be synchronized and not to be the usual one for shockable rhythm. Our 7 questions here. For a 5-year-old child is brought to the emergency department in an active generalized tonic-clonic seizure that has lasted for 10 minutes. You have already secured the airway and administered oxygen. Intravenous access has been just established. What is the next drug for the treatment? See here, he do the ABCs for the child. He is seizing, but he is giving the airway. He is giving supplementation of the oxygen. He administered the IV line axis. So we give before first three options of the benzodiazepine, which we will choose it now. Either it is rectal-diazepam, IV phenobarbital, IV lorazepam, or IV levetiracetam, or paclitaxel. Note the first next drug will be one of the benzodiazepine medication, not the others, which is the second options. So which we will choose? We will choose the IV lorazepam as the IV axis is there. According to the management for the algorithm of the status epilepticus, if the IV axis is available, IV lorazepam is the first line pharmacological treatment in the hospital setting. Paclitaxel preferred only if the IV axis is not yet established. Levetiracetam or phenytoin are used as the second-line treatment if the seizure continue after 2 doses of the benzodiazepine. Usually, this will be according to the time management. It will be minute of the 15, not 15, 10 minutes. So we are going after 10 minutes and to give the second medications. Let us here to cover some questions about dehydration and the shock. A 2-year-old child present with a fever of 39.5, an unblushing purplish rash, and capillary filling of the 4 second. The heart rate is 170. What is the initial recommended fluid bolus for resuscitations? From these descriptions, he is febrile with typical rash going with the sepsis. Capillary filling is prolonged and delayed. Heart rate is the higher side to compensate what happened for him. So we need to give him some support. Usually, for the fluid resuscitations, we are giving either 10 or 20 from preferable fluid, which is 0.9 sodium chloride. So let's see the options and let's see what we choose and why. 5 ml kilogram of 10% dextrose, 10 ml of kilogram of 0.9% sodium chloride, 20 ml per kilogram of 0.45 of the sodium chloride, 10 ml per kilogram of the 5% albumin, or 20 ml per kilogram of 0.9 sodium chloride. Usually, we will make our options to be choose either 10 ml of the sodium chloride or 20 ml of the sodium chloride. But if we give 20 in this child, shall we know the condition of his heart to give him high or no? Let's see the answer. Better here to start by the initial one, which is the 10 ml per kilogram of the sodium chloride. This is the child with the sign of the shock. We want only the initial management, including an immediate IV fluid boluses of the 10 ml per kilogram of 0.9 sodium chloride. The child to be reassessed after this bolus given. While order guideline sometimes suggests 20, the source is specified that 10 ml to be starting, noting that the urgent serial support is needed. If required, more 20. So we are here discussing what? Discussing the old knowledge. We can start by 20, but now better to start 10. If you need another more 10, better to consult the senior for that. And let's see what exactly mentioned in the new guidelines. Here they mention if the child is drowsy, agitated, confused, better to start immediate IV fluid through the 10 ml per kilogram from 0.9 sodium chloride. When there is a sign of the shock, saturation dropping less than 92%, clinically indicated, we will give him supplemental of the oxygen. And whenever required more than 20, better to ask urgent senior consultant with the BICU. So with the intensivist care, better to discuss with this and to give the second with regular assessment for his responses. Our last questions will be about continuation for these fluid resuscitations. A 2-year-old child with a 3 years history of profuse watery diarrhea and vomiting is assessed in the emergency department. On examinations, the child is lethargic, had sunken eyes, dry mucous membrane, with the heart rate of 155 beats per minute. Which of the following clinical finding is the most indicative for the clinical shock, necessitating an immediate intravenous fluid bolus? So we have some signs and symptoms already giving in the child history and prescribed for his symptoms, which will be more indicate that the child entering in the shock rather than to be only dehydrated. So reduce skin trigger or tachypnea or sunken fontanelle, capillary filling time more than 4 seconds, or the history of more than 6 times of diarrhea in the last 24 hours. Okay, let's us to make some analysis. Tachypnea and tachycardia, maybe it will be like initial assessment for dehydrations. Even like skin, sunken fontanelle, reduced skin trigger, it is a sign of the dehydrations. So let's see what he chose and to see the explanations corresponding to that. The right answer will be capillary refilling time of the 4 seconds. Why? He mentioned the difference between clinical dehydration and exactly definition of this what? It will be weight loss typically from 5 to 10%, while clinical shock, the weight loss will be more than 10%. The sign of the reduced skin trigger, tachypnea, sunken eye, dry mucous membrane, all these indicate clinical dehydration, not specified to the shock, while clinical shock characterized by the sign of the circulatory failure, including prolonged capillary fill, typically 2 seconds, more than 3 seconds, decreased level of the consciousness. That means alter of the consciousness level will be affecting either it is lethargic, it is drowsy, and so on. Pale, mottling skin, cold extremities, weak peripheral pulses. If the child present with this sign of the shock may require or they require an immediate IV fluid boluses of the 10 ml per kilogram or 0.9 sodium chloride. If we need to be again, we will consider whom? We will consider senior to be giving more than 20%, 20 ml per kilogram, as the previous explanation mentioned. While reduced skin trigger is a significant sign that warrant urgent referral to the hospital. It is categorized under clinical dehydration rather than high-risk red flags specifying defining shock. So what that mean? That mean if I am in the primary healthcare and I see these two signs, reduced skin trigger, it's better for me to refer him to the hospital to start the urgent things. But if I find the clinical shock, which characterized by these critical signs, it's better for me to start the IV fluid and to transfer him through ambulance, through paramedical care, or to going with him to the hospital or rapid access to near your regional part. To clarify all of this table give you the red flag for the clinical dehydration, which warrant for you high risk for progression for the shock. So what these things? He telling you his appearance become deteriorated, alter of the level of the consciousness, become more irritable or more lethargic in the both directions. Sunken eye, and the heart rate will be tachycardia, tachypnea in the breathing, reduced capillary filling. These signs, when you combined or you can find one of them, it's high risk to get progression for the shock. Better to initiate the fluid and to monitor him closely till he can get out from these and not enter in more deterioration part in the shock form. By this table, we reach our last slide, and we are thank you for listening to our lecture today. This is our reference for these lectures, and we hope all our mission is benefit for you preparing for the part 1, for the FOP and TAS from MRCB, and see you in next preparing video and next further topic to be administered by us. Thank you. Thank you.